Alright, so now let's move on to the opposite side of our spectrum. Alright, now your patient's coming with superficial bleeding, you get a bleeding time and it is prolonged. Next step was to get your platelet count. You get your platelet count and in fact it is decreased. Once the platelet count is decreased, what are the possible options, guys? It's either an increased breakdown in the periphery or your bone marrow is failing and your mnemonic is FIG, F-I-G. Alright, so now what I want to do is let's start off with your breakdown. There's increased platelet breakdown in the periphery. TTP, guys, when you think about TTP, what does TTP stand for? TTP stands for thrombotic thrombocytopenic purpura. Alright, so if I'm saying TTP, I'm pretty sure a bunch of you guys are saying, oh, this is the one with the pentad, right? Yes, it is the one with the pentad, guys. What is the pentad? Now let's look at this. Thrombocytopenia, MAHA, essentially meaning microangiopathic hemolytic anemia. You have acute renal failure, neurological symptoms such as stroke, and last but not least is fever. So these are the 5 symptoms. However, the most 2 important symptoms that must be present, because you're not always going to all 5 symptoms, guys. You're going to have one or the other. However, you must have 2 important symptoms. That is in fact going to be your thrombocytopenia and microangiopathic hemolytic anemia. And remember, when you have microangiopathic hemolytic anemia, you will start forming a certain cell known as helmet cell, and a helmet cell is also known as a schistiocyte, right? A schistiocyte, essentially a broken down RBC. Alright, now I could just leave it at this and tell you, you know what, you have to memorize this. But no, I'm not. What I'm going to tell you is you don't have to memorize anything. All I want to do is understand the disease, and you never have to memorize everything ever again. So let's talk about it. So let's try my approach on TTP. So why does TTP happen, guys? It's thrombotic thrombocytopenic purpura. The problem in TTP is the fact that you have a lot of von Willebrand factor multimers, right? So let me draw a blood vessel here, and I'm telling you there's a lot of von Willebrand factors roaming around in the blood. A lot of von Willebrand factors are roaming around in the blood because they cannot be broken. Well, who breaks down von Willebrand factor then? Von Willebrand factor is broken by a factor known as Adams 13. Adams TS13, also known as a metalloprotease. A protease breaks down proteins such as von Willebrand factor. So Adams TS13 is the factor that actually is job is to break down von Willebrand factor. Who produces Adams TS13 then? It is produced by the liver, guys. It's going to be produced by your liver. There we go. So your liver produces Adams TS13, and its function is to break down von Willebrand factor. Okay, so let's say you're not breaking down your von Willebrand factor. So what? What's going to happen? Check this out. So what I'm going to do is, this is your endothelial cell and this is your blood vessel. All right, this is your blood vessel, right? These are your endothelial cells right here. So I'm saying you have too much von Willebrand factor such that what does von Willebrand factor do? It forms platelet plugs, right? So you're going to start forming a lot of platelet plugs, right? Because you cannot break down this von Willebrand factor. Okay, so I'm starting to form these primary platelet plugs within my blood vessel, and what's happening is I'm forming a very big clot here and I'm narrowing my blood vessel. Okay, and here comes an RBC nicely swimming in your blood vessel. It goes through, it squeezes, it gets whacked, it gets whacked, it gets whacked, and it comes out looking like a helmet. Okay, what do we call this helmet cell, guy? Do we call it a schistiocyte? Yes, we do. And if your RBC is getting broken down when it goes through this, are you going to get a microangiopathic hemolytic anemia? Yes, you are. So there we go. That's the reason you're going to get your microangiopathic hemolytic anemia, because you're forming this clot within your blood vessel, and the RBC that goes through gets squeezed and destructed and broken down. It comes out looking like a helmet, schistiocyte, which is in fact crucial for the diagnosis of TTP. Alright, so that's your first symptom which you must have in order to diagnose a TTP. Number 2 that you must have is thrombocytopenia. Well, if you're forming a platelet plug, guys, are you going to use up platelets? Yes, you are, right? So obviously you're going to have thrombocytopenia. That's pretty easy. Alright, what about this acute renal failure and neurologic such as stroke? Well, what if this poor blood vessel was actually supplying your kidney? Would you get acute renal failure? Yes, you would. What if this poor blood vessel was supplying your brain. Would you get a stroke? Yes, you would. So that's the reason you would actually get these two symptoms, because it can occlude the blood vessels that are supplying your kidney or blood vessels that are supplying your brain and cause a stroke. Okay, fine, beautiful. What about fever then? Well, fever is because you're having a lot of inflammation going on here, right? A lot of inflammation, you're forming, you're activating a coagulation cascade and all these things. So what happens is you release interleukin such as 2, interleukin 6, which produces fever, and that's the reason you're going to have the fever. There you go. Now you don't have to memorize TTP at all, because you've understood it, guys. Pentad of symptoms, which is actually being explained. So now let's kind of trace back. You understood the pathophysiology. Excellent. Now the question is, what causes TTP? Who gets it? Why do they get it? Well, most of the time is actually acquired. All right, when you think about causes, most of the time it is actually acquired. So what happens is people who are exposed to certain medications, right, what happens is they produce autoantibodies against this Adams TS13. So I'm saying it is an autoimmune reaction. An autoimmune reaction because you give a patient a certain medication and this is triggering an autoantibody reaction against your Adams TS13. So what drugs are actually linked to this condition? You have drugs such as quinine, right? Quinine, an anti-malarial. You also have a medication known as ticlodipine. Ticlodipine, as you see, we don't use it very often because the risk of TTP is very high. Ticlopidine was actually an ADP receptor blocker, also known as your P2Y12 inhibitor, right? So ticlopidine can actually cause it too. But there are other medications as well which are actually implicated to cause the same condition but without an autoantibody reaction. And these medications are your cyclosporin, gemcitabine. Both of these are chemotherapeutic agents, guys. Now the way cyclosporin and gemcitabine actually causes a TTP is by causing direct endothelial damage and as a result triggering a lot of coagulation as well as platelet plug formation. All right, so basically forms platelet plugs here and causes the same pentad of symptoms, but it is not because it's producing autoantibodies against your Adams TS13. But quinine and ticlopidine does exactly that. All right, so either you could have an acquired form or you could have a genetic form where you actually have a decreased production of Adams TS13. A decreased production of Adams TS13 because the patient has a genetic inherited problem to produce Adams TS13. That's it. Most of the cases are because of acquired, guys, not the genetic type where you genetically lack Adams TS13. It's due to acquired. Alright, so you understood the causes, you understood pathogenesis as well. How are you going to treat these patients, guys? The treatment is going to be plasma exchange, guys. Plasma exchange is your treatment. So if you get a question, this is an emergency. All right, you want to do plasma exchange. Basically, you want to remove this patient's plasma with all these antibodies and give the patient a different kind of plasma now, right? You want to give him fresh plasma and you want to do exchange. And remember, when you have a patient with TTP, it is a medical emergency. You need to treat this patient with plasma exchange very, very rapidly, guys. What about giving platelets to this patient? It's a bad idea, right? The more platelets you give, what's going to happen is they're going to form more and more clots in different places and as a result worsen the patient's condition. So no platelets. You can do FFPs, however, most studies that has been done actually shows that giving plasma exchange is actually better than giving FFP directly. All right, so your answer for TTP is going to be nothing other than plasma exchange. HUS. All right, guys, so HUS, hemolytic uremic syndrome. Why the USMLE loves this so much, God knows. Anyhow, let's talk about it. It's a very interesting and a very nice topic to actually talk about. So HUS really stands for hemolytic uremic syndrome. All right, hemolytic uremic syndrome. So you know there's some form of hemolysis that's happening. You know there's some form of kidney damage that's happening because of uremia, and it's a syndrome, right? All right, so if you think about hemolytic uremic syndrome, there's actually two types, and the types are actually typical and atypical. All right, so typical and atypical. let's talk about the typical one first because it is typical, right? All right, so let's talk about it. Now what happens is, normally this condition actually occurs in a child. A child eats something and ends up getting a diarrheal illness, right? The kid comes with diarrhea. Now the moment the kid has diarrhea, you must think about what organism is actually causing this acute diarrheal illness. And oftentimes the organism that's actually implicated with HUS is E. coli, guys. In fact, a specific type of E. coli known as EHEC, enterohemorrhagic E. coli. All right, enterohemorrhagic E. coli. So essentially the diarrhea is not going to be just a water diarrhea, but it's going to be bloody, right? It's going to be dysentery. There's going to be a bloody diarrhea that precedes your HUS because of this bacterial infection. So EHEC 0157 is to H7, guys. This is the serotype. Now what happens? Let's try not to memorize anything and let's try to understand it. So what I'm going to tell you is a little story. So what happens is, I'm going to draw a blood vessel again in this patient as well, and the kid has got a dysentery, bloody diarrhea because of enterohemorrhagic E. coli. Now what happens is, this E. coli actually releases a toxin known as Shiga-like toxin. Now the moment I say Shiga-like toxin, you should automatically think, well, can Shigella cause this? Yes, it could, right? So I'm going to put Shigella up here too, because Shiga-like means your Shiga toxin can cause the same thing. So what happens is, this Shiga-like toxin actually comes, and if you guys can recall your ribosomal subunits of your cells, right? What do we have? 60 and 40S ribosomal subunits. 60 and 40S ribosomal subunit. So what happens is, the Shiga-like toxin or Shiga toxin itself comes and actually binds to the 28S subunit of your 60S ribosome and prevents protein synthesis. That's what it does. So if it prevents protein synthesis, and if I draw endothelial cells again, guys, do you need to produce protein in your endothelial cells? Yes, you do, right? Because everything in the cell, you need to produce protein to form certain important pumps, such as your sodium, potassium, ATPase pumps, right? The pumps actually that maintain the integrity of your endothelial cell. Your sodium, potassium, ATPase pump maintains the integrity of your cells. So if I tell you, if this patient, this kid who has dysentery, bloody diarrhea, has EHEC and produce Shiga-like toxin, and the Shiga-like toxin inhibits protein synthesis in the cell, can you not form these sodium, potassium, ATPase pumps? Yes, right? You cannot form it. As a result, what's going to happen? Your cell cannot maintain the cellular integrity. Your cell's going to swell up, become fat, and next thing happens is an breakdown of your endothelial cell. If you break down endothelial cell, the same steps follow, guys. Exposure of some endothelial collagen, 1 Willebrand factor binds, and essentially meaning, what I'm trying to say is, you are going to form a platelet plug. You're going to form a platelet plug here, you're going to form a platelet plug here in your endothelial cells. Now your blood vessel is becoming narrow, and here comes your RBC again, doing a jolly good ride in the blood vessel, right? Gets whacked, and comes out looking like a schistocyte. There we go. The moment I say schistocyte, you should say microangiopathic hemolytic anemia along with presence of schistocytes, also known as helmet cells, right? So do you get this feature in your hemolytic uremic syndrome? Yes, you do. Now, what other symptoms do you get? You should get a triad of symptoms essentially in a patient with HUS. One is microangiopathic hemolytic anemia. Number 2 is thrombocytopenia, guys. Thrombocytopenia, decreased platelet count, right? Why do you get a decreased platelet count? Is because you're consuming your platelets to form these clots in your blood vessels, right? All right, and number 3 is actually uremia due to acute renal failure. How does this happen? Again, what if this blood vessel was supplying your poor kidney, guys? What's going to happen? You're going to get decreased flow to your kidney, and as a result cause a acute renal failure causing uremia. So this is your triad, guys. Thrombocytopenia, microangiopathic hemolytic anemia with a schistocyte, and finally acute rheumatic fever. Also, just to add on, guys, anytime you get a microangiopathic hemolytic anemia, remember you are going to get elevated levels of LDH because lactate dehydrogenase is present in pretty much every cell. So the moment you damage cells such as RBCs, you will release out of LDH. You can also have elevated bilirubin levels, right? Because you're going to be breaking down your hemoglobin and eventually releasing bilirubin, right? So these are important things you're going to actually pick up in your test as well. So fine, HUS, you know the organism that's causing it, you know why it causes it, and how you get your triad of symptoms without memorizing a word. Perfect. Okay, so this is your typical HUS. Okay, what is atypical? In atypical HUS, the syndrome is not precipitated by a acute diarrheal illness. Why it happens is because overactivation of your complement cascade. In atypical, it is due to overactivation of your complement cascade, guys. That's it, right? So why it happens, we don't completely know, but we know it is because of your overactivation of your complement cascade. All right, so the reason, again, why is it so important to know whether it's a typical HUS or it's an atypical HUS? Because atypical HUS, you actually have treatment, guys. What is the treatment for atypical HUS? You basically want to give a drug that actually binds to C5, your complement factor 5. All right, so the drug that you're going to be using is going to be called eculizumab. The mechanism of action, it actually binds to C5 and prevents it from going to C5a. It does not get activated to go to C5a, which is a very potent anaphylatoxin. All right, it causes all these problems, overactivation. So basically eculizumab binds to C5 and blocks your terminal complement cascade. That's what eculizumab does. So it's a very good drug and actually excellent for treatment of atypical HUS. Another place where you'll see you're using eculizumab is paroxysmal nocturnal hemoglobinuria, which also happens because of your terminal activation of your complement cascade. It's all connected, guys. From every place you need to connect. You need to make connections so you retain better. Alright, guys. So this is your eculizumab. Another important point that I need to add on to your eculizumab is anybody who gets eculizumab must be given a vaccine to a certain infection prior to giving them the drug. Which infection is this, guys? Think about it. What infection could happen if you block your terminal complement cascade? Are you guys saying Neisseria? Yes, you are, right? Remember, you also learned about a condition when you have terminal deficiency of complement factors, you can get a lot of Neisseria infection. So anybody who's going to get eculizumab must be vaccinated against Neisseria meningitis prior to actually giving them the drug. So that's the treatment of atypical HUS. What about typical HUS then? It's all supportive, guys. Supportive treatment is all we have for a typical HUS. Alright, so this completes our section on HUS. Heparin-induced thrombocytopenia. As you guys know, heparin-induced thrombocytopenia, also known as HIT, is actually a very important topic. So why does it happen? Again, we see this a lot in the hospital setting, so therefore it is actually a real problem, and that's the reason the USMLE is after it by asking a lot of questions on it, right? So when you think about heparin-induced thrombocytopenia, why does it happen? It happens because somebody is exposed to any form of heparin products, all right? Any form of heparin products, but most commonly your unfractionated heparin is notorious to cause this problem. What about lower molecular weight heparin? Could it cause this problem? Yes, it could. However, unfractionated heparin is very much more notorious in causing heparin-induced thrombocytopenia. That's the reason we try not to use so much of unfractionated, because we have lower molecular weight heparin and which could be used less frequently in the hospital setting. All right, so unfractionated heparin the patient is going to be getting. For instance, say patient gets heparin, and then what happens is your platelet factor 4, guys, there's a platelet factor 4 present in your platelets, right? Here's a platelet factor 4 which basically binds to your heparin. Your heparin binds your platelet factor 4, which is your platelet. So there's two components. Basically, my point I'm trying to make is it's an immune reaction. It is an immune reaction, which means you need an antigen and an antibody. So what is the antigen? That's the question. The antigen is a combination of heparin and your platelet factor 4. All right, so this becomes your antigen. Now your body recognizes this and produces auto antibodies against this and causes two things. What it does is when you have auto antibody against this, you're going to be decreasing your platelet count, because now you're going to start destroying your platelet count, right? You're going to start destroying your platelet. What's going to happen is you're going to have a result of two things, guys. As it is an immune reaction, there's going to be a certain component of destruction of platelets. So number one, you are going to get thrombocytopenia, right? thrombocytopenia is going to be present. Number 2, which is kind of the weird thing about heparin-induced thrombocytopenia, is there is thrombosis, guys. There is going to be thrombosis. So what happened is, because these patients are having this autoimmune reaction between your heparin platelet factor 4 complex and antibody, you're going to have an immune reaction, and as a result, in your blood vessel, you're going to start forming clots. You are going to start forming clots in your blood vessels. All right, you're going to start forming clots in your blood vessels, so you will have thrombosis. But apart from that, you will also have a decreased platelet count due to 2 reasons: autoimmune destruction as well as consumption of your platelet count. So that's what you are going to get a heparin-induced thrombocytopenia. So how are you going to evaluate and say, okay, does this patient have a low likelihood of heparin-induced thrombocytopenia, maybe a moderate likelihood, or is it a high likelihood? How are you going to say this? It is based on your 4T scoring system. First T is thrombocytopenia. Number 2 is the timing of platelet decrement. What is the timing between when the patient was exposed to heparin and when did the platelet count actually start to decrease? Number 3 is thrombosis or other sequelae, right? Is there thrombosis or any other form of sequelae that's present because of the heparin-induced thrombocytopenia? And lastly, you have other causes of thrombocytopenia. Is it present or not? So these are your 4 T's, guys. Is there thrombocytopenia? Number 2, the timing of platelet decrement. And number 3 is there thrombosis? And number 4 is, are there any other causes for development of thrombocytopenia in your patient? Alright, so now let's kind of dissect each one of them. Thrombocytopenia, your magic number, guys, is this: you must have a more than 50% decrement of your platelet count in order for you to actually get your 2 points. Alright, so if you have a decrement more than 50%, you will get 2 points for your 4T score. Whereas if you have a 30 to 50% decrement in your platelet count, then you will only get 1 point. Whereas if it's less than 30%, it's very highly unlikely to be heparin-induced thrombocytopenia. Now, the timing of platelet decrement, the clear onset, guys, the most typical form of heparin-induced thrombocytopenia actually happens between 5 to 10th day, between your 5th to 10th day from the onset of exposure of heparin. From the time of exposure of heparin, you should take about 5 to 10 days within which you will have to see your drop in your platelet count. So if it is actually between 5 to 10 days, then this patient is going to get 2 points. Whereas if your platelet count decrement occurs below 4 days or below 5 days, at this point it is less likely to actually be heparin-induced thrombocytopenia. Alright, so this is the timing of platelet count. It has to be between 5 to 10th day. So the bottom line, if I had to recap these 2 points, you want a decrement to drop more than 50%, and it needs to happen from the 5th to the 10th day. Thirdly is the presence of thrombosis, guys. If there is thrombosis, a clot is present, you've seen a DVT, may it be the arms, may it be the legs. If that's present, now your patient is going to get 2 points there as well. And obviously, last but not least, we are going to see for other causes of thrombocytopenia. If no other causes are apparent at all, this patient is going to get 2 points. Now again, if you had to recap this whole table, what's the point of you actually using this table is to determine if your patient has a high probability, intermediate probability, or low probability. So 6 to 8 points, guys, is high probability. Intermediate is going to be 4 to 5 points, whereas low probability is going to be 0 to 3 points. So based on your 4T scoring system, you guys determine is it a low probability, moderate probability, or high probability. Alright, fine. So all and well, once you've determined that, how are you going to test to see if this patient actually has heparin-induced thrombocytopenia? You will look for an antibody. What is this antibody called? If you guys recall, I told you the antigen was between heparin and platelet factor 4, right? And you had an antibody against this. And what is this antibody called? It is called heparin/platelet factor 4 antibody. Basically, it is an ELISA test. Basically, you're testing for the presence of this antibody, guys. So this becomes your best initial test. Heparin/platelet factor 4 antibody is what you're going to look for. If that is not conclusive, your next test is going to be a serotonin release assay. Alright, your next best test is in fact going to be a serotonin release assay. All right, and based on these two tests, you can actually diagnose to see if your patient has heparin-induced thrombocytopenia. All right, what do you need to do? What are you going to do next, guys? Your patient has heparin-induced thrombocytopenia, which means if he's having it, there's a high likelihood that this person has probably got, these are the arms and legs, guys, arms and legs. He's probably got a clot here, 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 here. So does that mean you must do another test in this patient? Anybody who's suspected to have heparin-induced thrombocytopenia must have a venous duplex. A venous duplex of all four extremities, guys. All four extremities. You must do a venous duplex to see if there is clots or not. So that's one important thing that you are going to do. A venous duplex. What else do you need to do? Are you going to stop the heparin? Please do, guys. Please stop the heparin. Number 3, I'm going to put here, stop the heparin. Stop heparin. But moment you stop heparin, the patient is still prone for thrombosis, right? He's prone for thrombosis, which means you must anticoagulate these patients, right? You must anticoagulate. What is the anticoagulation of choice? Your choice becomes argatroban. Your choice of treatment or anticoagulation in these patients is actually argatroban. All right, argatroban. You can also use fondaparinux. These are going to become your choices, right? Argatroban or fondaparinux. But for all practical purposes, just remember your argatroban. That becomes your drug of choice. All right, so you'll start the patient on argatroban immediately. Stop heparin, start argatroban immediately. Next question is, how long are you going to treat this patient with anticoagulation? So the question really is, you have to ask yourself two things. If you're starting the patient on argatroban, which is your choice of anticoagulation in heparin-induced thrombocytopenia, your next two questions you need to ask is, what is the patient's platelet count and does the patient have thrombosis? So for instance, if I told you the patient has a platelet count less than 150,000, right? And the patient does not have thrombosis. So there is no thrombosis, but the patient has a platelet count less than 150,000. At this point, what you're going to do is you will treat this patient with anticoagulation until your platelet count goes above 150,000. That's your treatment. All right. So if there's no thrombosis, you focus on your platelet count. Get your platelet count above 150,000 and then you can stop the anticoagulation. All right. What about number 2? What if this patient actually had a thrombosis? He had a thrombosis. In this case, you will treat the thrombosis like a regular thrombosis. If you have a DVT, 3 to 6 months of treatment, right? So you will treat the patient's thrombosis with anticoagulation for about 3 to 6 months, all right, depending on where the clot actually is. So you will just follow your regular guidelines for how long the anticoagulation is going to be used in a patient if he has thrombosis. Another important question is, can this patient ever be exposed to any other heparin products after this? No, the answer is no. The patient should never be exposed to any other heparin products ever in their life. So this concludes the section on heparin-induced thrombocytopenia, guys. It's a very, very high yield topic. You must know all these facts.